Hi everyone. Today I come up with another video that is cardiomyopathy. So when you see the videos, that is in the previous sections I was teaching about the cardiac disorders. So cardiomyopathy also a cardiac disorder. So we can see the details. What is cardiomyopathy? So when you see the term cardiomyopathy, it is a disease in the heart muscles. So cardiomyopathy is a heart muscle disease associated with the cardiac dysfunction. In more detail, it constitutes a group of diseases that directly affect the structural or functional ability of the myocardium. So, the classification. What is the basic classification of cardiomyopathy? When we see the classification of cardiomyopathy, mainly we see the WHO classification. We see the here we see the classification according to the structural and functional abnormalities of the heart muscles. The first one is dilated cardiomyopathy. In short term, we can see DCM. Then hypertrophic cardiomyopathy, restrictive or constrictive cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, and unclassified cardiomyopathy. So classification according to World Health Organization is mainly classified into three, that is dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. So this is the picturization which shows the normal heart as well as the cardiomyopathic features. So when we see the normal heart, we can see there is a ventricular size and the wall uh, size of the ventricular wall, otherwise myocardial thickness. So normally there is enough space for collect the blood in the ventricles. So when we compare with the normal picture, we can see the difference in the what is the feature in the dilated cardiomyopathy, what is the feature in the hypertrophic as well as restrictive. In dilated cardiomyopathy, the myocardial wall is dilated, so it loses its what is that systolic function or contractile ability, and where there will be have the more pooling of blood. Similarly, in the hypertrophic cardiomyopathy, the size of the ventricles are increasing in size, so there is no enough space in the ventricle to collect the blood, and thereby it reduces the cardiac output. Similarly, in the restrictive cardiomyopathy, the muscle wall is thickened as well as it is something like a akinetic. That is, the kinetic activity is absent. We can see detail about each of the type of cardiomyopathy. The first one is dilated cardiomyopathy. As it is says in the term, the dilated cardiomyopathy, it is significant dilation of the ventricles without significant concomitant hypertrophy, in the sense without increased muscle wall thickness, there is a dilation of the ventricles, and thereby there is a loss of systolic dysfunction. Then the picturization shows this is for the normal cross section of the heart, and here it is the dilated ventricles. When there is a dilated ventricle, the muscle wall thickness is not changing, but it is dilated and it loses elasticity, or the systolic function will be affected. So we can see the pathophysiology. Before that, see the etiology. The etiological factors are cardiotoxic agents like alcohol or cocaine, then genetic predisposition, that is as it is genetic predisposition in the sense those who have the family history, otherwise the first degree relatives, if they have the history of cardiomyopathy, then that's the most risk for developing cardiomyopathy. Then hypertension, increasing blood pressure. Then ischemia is the myocardial ischemia, there is a myocardial cell death that is secondary to coronary artery disease. Then muscular dystrophy, that is weakening and wasting of muscles. Myocarditis, that is inflammation in the myocardium. Then pregnancy and valve disease. These are the certain etiology as well as risk factors of developing dilated cardiomyopathy. Then the pathophysiology says it is characterized by diffuse inflammation and rapid degeneration of the myocardial fibers. So because of that, what happens? There is a ventricular dilation. That is, ventricle dilates. So because of the ventricular dilation, there is an impairment of systolic function. Systolic function, as you know, that is ventricular systole or ventricular depolarization. So that will be affected. So there is a systolic dysfunction. Then that leads to atrial enlargement and stasis of blood in the left ventricle, that leads to cardiomegaly. Finally, because of stages of blood, we can see the next step. Because of stages of blood, there is a less blood is then able to enter the ventricles during diastole. That is because of it is a dilation of the ventricles, the collected blood will be stagnated over there. So because of the dilation, the ventricles lose its systolic function. That is what its contractile function is a deficit. So more blood will be pooled in the left ventricle. So further there is no space for the further collection of blood, thereby decreasing the cardiac output. Then increasing the end diastolic pressure, and eventually increase the pulmonary pressure. That leads to altered valve function can result from the enlarged stretched ventricles, usually result in regurgitation. And similarly, there is a because of pooling of blood, embolic events caused by ventricular and atrial thrombi as a result of poor blood flow through the ventricles may occur. So finally, there is a decreased cardiac output. Then what are the clinical features in the dilated cardiomyopathy? First one is a decreased exercise capacity. In the sense, the patients or the persons cannot perform activities, even the activities of daily living. If they perform the daily activities also, they easily get fatigue or tired. They cannot perform it well. Then fatigue, dyspnea, paroxysmal nocturnal dyspnea, and orthopnea. Then as the disease progresses, they have dry cough, palpitation, abdominal bloating, nausea, vomiting, anorexia, abnormal S3 and S4 gallop, then tachycardia or bradycardia, edema, then pulmonary crackles, weak peripheral pulse, hepatomegaly, and jugular venous distension. That is, once there is a dilated cardiomyopathy, it starts from the left ventricle, but if it is not controlled, then it will end up with the core pulmonary and right heart failure. So that is why initially start with the cough and the left ventricular failure features, finally end up with the right heart failure features like hepatomegaly, jugular venous distension, edema, that is a pulmonary crackles, and weak peripheral pulse, and all features are there. Then the diagnostic measures are, as it is for all conditions, the history and physical examination is the first and foremost diagnostic investigation. That is, if you collect a proper history and do a perfect assessment, 90% of disease can be revealed through the basic history and assessment. Then advanced diagnostic measures like echocardiography, then chest X-ray. Chest X-ray show the sign of cardiomegaly, that is increasing the size of the heart, especially increasing size of left ventricle. Then ECG. ECG shows tachycardia, bradycardia, and dysarrhythmias. Then cardiac catheterization or angiogram. It is performed to confirm coronary artery disease, as well as cardiac catheterization reveals the chamber pressures of pressure of right atria, left atria, right ventricle and left ventricle, and it analyzes the structure of valves and valvular function, and also we can analyze the blood circulation throughout the chambers and throughout the heart and all. Similarly, angiogram analyze the patterns of coronary artery. Then management for dilated cardiomyopathy. So first drug of choice is nitrates. So drug of choice nitrates, example isosorbitrate, or similarly nitroglycerin, all kinds of drugs are there. Then loop diuretics, furosemide. If there is a fluid overload, it will reverted by administration of loop diuretic. Then AC inhibitor. AC inhibitor in the sense angiotensin converting enzyme inhibitor, that is drug of choice captopril. It will uh, prevent the conversion of angiotensin 1 to angiotensin 2. Thereby, it will reduce blood pressure as well as it will improve the vasodilation, and it will improve the blood circulation. Then beta adrenergic blockers, atenolol. Beta blockers, it will reduce the contractilities, thereby reduce the heart rate, thereby it will reduce the cardiac metabolic demand or the cardiac workload demand. It will reduce the workload. Then aldosterone agonist, that is spironolactone, that is also helpful for the relieving the fluid overload and dyspnea, fluid congestion and all, improve the perfusion. Then cardiac glycosides, digoxin, and anticoagulation therapies. Anticoagulation therapies like heparin, that is a low molecular weight heparin is the most appropriate. Now, surgical management is heart transplantation. That is, in case the patient is in the end stage of heart failure, we can go with the heart transplantation. The second type of cardiomyopathy is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, there is an asymmetric left ventricular hypertrophy, especially asymmetric left ventricular hypertrophy without ventricular dilation. So the size of the ventricle is the same, but the ventricle wall, there is a myocardial wall thickness or the increasing size of the myocardial wall. So in hypertrophic cardiomyopathy, the heart muscle increase in size. That is a significant feature. The heart muscle increase in size and mass, especially along the septum. So also been called idiopathic hypertrophic subaortic stenosis or asymmetric septal hypertrophy. The other terms for the hypertrophic cardiomyopathy. This is a picturization. This is a cross section of heart, shows normal heart as well as the hypertrophic cardiomyopathy. Here it is easily, this is visible, that is enlargement of the heart muscle. So what happens, there is a decreasing size in the left ventricle. The etiological factors are aortic stenosis, genetic predisposition, hypertension, more common in men between the age of 30 to 40 years. And the pathophysiology shows thickened intra-ventricular septum and ventricular wall that leads to ventricular hypertrophy. Because of ventricular hypertrophy, there is a diastolic dysfunction of the ventricle that leads to impaired ventricular filling and obstruction of decreased outflow that leads to decreased cardiac output. This is a pathophysiology of the hypertrophic cardiomyopathy. Then what are the clinical features? Exertional dyspnea, there is shortness of breath during exercise. Definitely, when there is a decreased cardiac output, so body demands, when we are doing any exercise, when we are doing any strenuous activity, body demands more oxygen. So when oxygen demand increases, patient end up with the shortness of breath. Actually, there is a compensatory feature of the decreasing cardiac output. So decreased cardiac output. Usually we know normal cardiac output is, that is the ejection fraction is 55 to 70 percentage. So when there is a decreasing stage, patient end up with the further problems like vital organ perfusion will be interrupted, peripheral perfusion will be interrupted. Then similarly patient come up with the shortness of breath or dyspnea stage. Then fatigue, angina, that is because of decreased cardiac output, decreased coronary perfusion that leads to anaerobic glycolysis and lactic acid secretion, that is the reason for the angina. Then syncope and hypertension. Then the diagnostic studies are history and physical examination, echocardiogram. In echocardiogram we can rule out the ejection fraction. Similarly we can rule out the myocardial activity. Then we can find the valvular activities and all things we can reckon in the echocardiogram. Then electrocardiogram, ECG also shows the abnormal electrical rhythm as well as any arrhythmias and all. Then cardiac MRI, that is a scan, MRI scan the cardiac. Nowadays we are going with the angiogram and all. Then cardiac catheterization, that is the invasive procedure. Then management for hypertrophic cardiomyopathy includes beta adrenergic blockers, that is atenolol. It will reduce the cardiac workload and also it will reduce the heart rate. Then calcium channel blockers, example verapamil. Then anti-dysarrhythmic drugs, drug of choice is amiodarone. Then surgical management is septal myectomy. Already said there is a increasing size of the left ventricular wall, including the septum. So septal myectomy reduces. So this is an open heart surgical procedure to which the surgeon remove the part of thickened, overgrown septum between the ventricles. The next one is septal ablation. Septal ablation in the sense, a small portion of the thickened heart muscle is destroyed by injecting alcohol through a long thin tube into the artery supplying blood to that area. The next is the implantable cardioverter-defibrillator. In short, we say ICD. ICD, that is something, what is that? To patients who suspect with dysarrhythmia or recurrent arrhythmias, the treatment modality is implantable cardioverter-defibrillator. It will recognize the rhythm and it will deliver the shock. So, this is something seems same as the permanent pacemaker. This device can identify the rhythm and it will revert the rhythm by delivering a shock. And third type of cardiomyopathy is the restrictive cardiomyopathy. So restrictive cardiomyopathy is characterized by diastolic dysfunction caused by rigid ventricular walls that impair the ventricular stretch and diastolic filling. So that is what the ventricular wall seems more rigid, or it will not expand. It will affect the systolic as well as the diastolic function of the ventricular wall. This is a picturization shows normal as well as the restrictive cardiomyopathy. The walls of the ventricles become stiff but not necessarily thickened. There is not much thickness, but the walls are the stiff nature. Otherwise, it will not expand. It is not smoothen, or the contractility function or the diastolic and systolic function is affected. So the etiological factors, most often it is says it is an unknown etiology. Other feature factors are myocardial fibrosis, endocardial fibrosis, sarcoidosis, and radiation to the thorax. The pathophysiology shows due to the etiological factors, the stiffness of the ventricle wall with the loss of ventricular compliance, that is, ventricular function is affected. The normal ventricular function is systole as well as diastole. So because of that, what happens? Ventricles become resistant to filling. There is less space, as well as ventricles will not get adequate blood over there. That leads to decreased cardiac output. So the clinical features includes fatigue, exercise intolerance, dyspnea, orthopnea, that is shortness of breath, which occurs when lying flat, and syncope, palpitation, peripheral edema, jugular vein distension. So the diagnostic studies, that is most often the same. Similarly, health history and physical examination, and chest X-ray shows cardiomegaly. Then ECG shows tachycardia, and echocardiography for the visualization of left ventricle. Definitely we can visualize the chamber and we can identify the ejection fraction, identify the valvular activity. Most often in restrictive cardiomyopathy, the ventricle wall will be akinetic, and similarly there is a filling pressure will be more. Then CT scan and MRI scan. Then management for restrictive cardiomyopathy, beta adrenergic blockers, drug of choice is atenolol. Calcium channel blockers, drug of choice verapamil. Then steroids, especially the drug of choice is hydrocortisone. And antiarrhythmic drugs, drug of choice is amiodarone. Then heart transplantation is the surgical correction. That is, if there is in the end stage of disease, go with the heart transplantation. And the nursing management. What is the nursing management for patient with cardiomyopathy? So first of all, instruct the patient to take all medicines on prescribed time. Encourage to use low sodium diet, as it is we see in the patient have hypertension, increased blood pressure. So advise to take less sodium diet. The instruct to drink more water. Drink water, that is if indicated. So if the certain patients, if they have any renal incompatibility, then advise to have the fluid level as prescribed. Then instruct the patient to maintain proper body weight. Then teach the patient to balance activity and rest, because they cannot perform heavy activities at a stretch for a long time, because they have the heart is not compliance to the best level. So they're supposed to perform the activity in between rest, then only the heart can cope up with their activity level. Instruct the patient to avoid vigorous activities and exercise. And encourage the patient to perform stress reduction activities. Stress reduction activities is yoga or any meditations. So stress also that will improve the metabolism as well as it will increase the cardiac function. So cardiac workload will be increased. Then teach about breathing and coughing exercise. Suggest the family members to learn about CPR, because in case of any emergency comes, teach them CPR to give the first aid to the patient. This is about cardiomyopathy. So in this section, I taught you about what is cardiomyopathy, what are the basic types of cardiomyopathy, that is dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. Then each of the condition, what is the etiological factors, what is the pathophysiology of particular aspect, and its clinical features, diagnostic tests, as well as management for each type of cardiomyopathy. I hope you understand about that. Thank you.